morphology study for early prediction of bleb failure. The basic careful slit lamp evaluation of post-trabeculectomy bleb morphology can predict in a reasonable way whether the bleb is going to be functional, enabling early steps to maintain the target intraocular pressure and prevent disease progression. Everywhere the AIOCT is not available, so at least a basic slit lamp evaluation can predict the bleb function. This is the purpose of this study. Only 10 trabeculectomies are done by standard technique without anti-metabolite, and patients were followed up day 1, first week, and 4th week, 3rd month and 6th month post-operatively. And key considerations were the bleb height, bleb extent and the vascularity of the bleb. Coming to the first day bleb, it's a functional bleb in the left side with well-formed cystic bleb and normal conjunctival vascularization. This was followed for 6 months regularly, and it was a functional bleb. From the first day appearance, this can show whether the bleb is going to be functional or not. And the right side, the bleb was flat. Because it was flat, and after digital message also it was not well forming, and this bleb early intervention was done, but at the end of 6 months this bleb failed. And in the left side, this bleb was after 1 week. This was a cystic diffuse area bleb and with normal conjunctival vascularization and posteriorly draining bleb. This bleb without any medication, this maintained its intraocular pressure after 6 months also. This is a nice bleb. And in the right side, the bleb on the first week post-op, it was a flat vascularized bleb. This bleb failed with intervention also after 6 months. And after 4 weeks, this is a bleb which is a wide cystic area bleb with normal conjunctival vascularization draining posteriorly. This is a nice bleb, and this maintained without any medication after 1 year also. This was right in the right side, this bleb was flat and vascularized bleb. This is a failing bleb after intervention also. And in the left side, after 3 months post-op period, this is a nicely formed avascular cystic posteriorly draining bleb. And in the right side, this bleb was encapsulated cystic bleb but and vascularized. So much of vascularization, this is sign of failure. And this bleb after 6 months, this is avascular cystic bleb and microcysts are well formed, which is in, and this is a functioning bleb. And in the right side, the bleb was encysted with a demarcation line and with conjunctival vascularization. This is a failing bleb. So this bleb was graded accordingly Indiana bleb appearance gradation system, and accordingly one can know in a very quick way whether the bleb is going to fail or not. So to conclude, the excessive vascularization, flat thick walled blebs and encysted blebs with demarcation lines were very early signs that this bleb is going to fail. So intervention is required in an early stage so that the bleb function can be maintained. And this problem is not very uncommon. Post-operatively trabeculectomy bleb failure is commonly encountered situation for all glaucoma surgeons. It might be due to various reasons starting from preoperative, intraoperative and post-operative causes, and careful examination and proper documentation at each follow-up visit by a basic slit lamp examination, if the higher instruments are not available, can predict whether the bleb is going to fail or not, so that early steps can be taken to maintain the target intraocular function and to preserve the visual function. Thank you so much for your attention.
Thank you, Dr. Rita. That was an excellent presentation. I just wanted to ask, were all the surgeries titrated in the same way? Did you use the same mitomycin? Did you use them for the same period of time?
It was without antimetabolite, single surgeon, and in the same way, 1 apex suture and 2 side sutures, and only titration.
So,
after titration.
Okay. All right.
Only titration.
Thank you so much.
Welcome.
Thank you for keeping to the time. And I also had a question that do you, you are not at all discussing the intervention, like if you found that a bleb was not good right on the day 1,
Yeah.
then what did you do? Because did that help? Because some patients...
Yeah, purpose was that why we are studying the morphology, because of time constraint, I have not mentioned all those things. In the first day slide I showed in the right side, the blade was flat. We gave the digital massage. If the digital massage it was forming, then it's well and good, we are waiting. If it's not forming, then we are going for a suture lysis. Intervention was done.
Okay, thank you.
Yeah, thank you.
No problem.
Dr. Rekha? As we are running short of time, can the next speaker be ready? The next speaker, Dr. Surbi, is not here. So, you've joined us. Okay, you're next then.
Good afternoon. My free paper on amniotic membrane as a wound modulator in trabeculectomy. Trabeculectomy is the procedure of choice as a surgical treatment for lowering the intraocular pressure by creating an artificial drainage from the anterior chamber into the subconjunctival space. The success of which is primarily linked to the subconjunctival fibrosis, which is prevented by the existing agents like mitomycin C and 5-fluorouracil. But they have complications which have been well established, which is the following. Amniotic membrane, it inhibits fibrosis by downregulating the transforming growth factor beta. It provides a framework and basement membrane for the filtering bleb, and muted healing responses present. The objectives primary being to evaluate the efficacy of amniotic membrane transplantation in trabeculectomy, and the secondary being the outcomes and complications that are seen. The study design is a prospective longitudinal interventional hospital-based study where 30 patients with primary glaucoma were included. Inclusion criteria, primary glaucomas which are uncontrolled and they have a rapid progression, and exclusion criteria being secondary glaucomas. The methodology, a partial thickness rectangular flap of 2 × 2 mm was raised, and if it was a combined procedure, a linear incision temporal to it was taken. Anterior chamber was then maintained with air after paracentesis. Sclerostomy was performed with Vannis scissors, and the scleral block was excised using Kelly sponge or Vannis. The scleral flap was then sutured with 10-0 nylon. 4 × 4 mm amniotic membrane was cut and then placed over the scleral flap, and the conjunctival flap was sutured with 8-0 Vicryl and stromal hydration and subconjunctival injection of Genta plus dexamethasone was given. Post-operatively, the patient was followed up for 3 months where visual acuity, post-operative IOP and slit lamp examination for the bleb characterization was done based on move fields. So the results, the age range of the patients were 50 to 82 years, and majority were in 61 to 70 years. 24 were primary open angle glaucoma, 5 were normotensive, and 1 was primary angle closure glaucoma. The IOP seen was at the end of 3 months, 43.3% reduction was seen with a p-value of less than 0.001. So it was significant. So the bleb characterization is as follows. Moderately elevated blebs were around 50%, and 53% showed mild vascularity, 80% had a central bleb area of 25%, and 53% had a peripheral bleb area of 25%. The complications encountered were hyphema, subconjunctival hemorrhage under the bleb, the incomplete peripheral iridectomy during surgery, and posterior capsular rent, toxic anterior segment syndrome, which did not show any long-term, which were managed and did not show any long-term complications. The outcomes being complete success of 25 patients, 83.3%, and qualified success of 17%. Discussion. Stavikas et al. Compared two groups, that is amniotic membrane
Time is
versus
over.
conventional.
Time is over.
Yes.
Time is over, actually.
Shall I just wrap it?
You can continue in finishing it,
Yes,
but you've exceeded your time.
Yes, ma'am. Amniotic membrane of the study group showed diffuse with mild vascularity, and the control group showed a flatter vascularized bleb. The Eliza et al., which had mitomycin C plus amniotic membrane in the study group, showed thin avascular blebs, and 62.5% showed flat vascularized bleb in the plain MMC group. So the intraocular pressure in these studies were not significantly different. The conclusion is the present study says that amniotic membrane transplantation is both safe and efficacious, and the reduction in IOP is clinically significant, with showing diffuse mild vascularity at the end of 3 months having total success.
Thank you. Just one question that
Yes.
there was no control for this, right?
There was
Control arm.
no, it was a interventional longitudinal study of 30 patients, ma'am.
Okay.
It was not an RCT.
Okay.
Okay, let's move on to Dr. Surbi. One question.
Dr. Surbi is going to present management of occlusal pupillae, secondary glaucoma, and complicated cataract, a case report.
Good afternoon, everyone. I'm Dr. Surbi Taneja. Thank you, AIOS, for selection of my poster for the Hyde Park. As we all know, uveitis, it affects 2 million people worldwide, and 10% of them, they suffer irreversible visual loss due to different complications like the retinal damage in glaucoma. Glaucoma is the third most common complication, the first two being the macular edema and cataract. And 40% of those patients can develop cataract. So in those cases where there is a cataract, uveitis, and glaucoma, it can be a very tricky case to manage. The cataract and glaucoma not only occurs due to the uncontrolled and sustained inflammation, but also due to the prolonged use of the steroids in all different forms. Chronic anterior uveitis can lead to occlusal pupillae, which can lead to a pupillary block glaucoma, and later on there could be formation of the iris bombae and a secondary angle closure can occur. So, a patient, 64-year-old male, presented with pain in the left eye, and he was a diabetic and had coronary artery disease and was on antidepressants. He also had a history of recurrent uveitis. All the tests were done for which there was no positive test. And the last attack was 8 years ago. The patient was already on anti-glaucoma medication, Dorzox, brimonidine, and timolol combination, and homitropin in the left eye. The right eye was, on examination, the right eye was within normal limits, and the left eye, the vision was perception of light was present, and the projection of rays was inaccurate. The IOP was 48 on GAT. Slit lamp showed circumcorneal congestion, corneal haze, and as you can see in this picture, the AC was very shallow. It was almost flat in the periphery, and there was occlusio pupillae present. Anterior segment OCT confirmed our findings, clinical findings. B scan was done to see if there was anything in the fundus because it was not visible. So what we did was, in such a case where there was occlusio pupillae present, we used ND-YAG laser to perforate that membrane to temporarily lower the IOP, which we did by setting it at anteriorly and at a very low energy. So the membrane, as it perforated, it led to the deepening of the chamber, as you can see in this E figure. And there was also a small hyphema, but that resolved, and we put the patient on the systemic and topical anti-glaucoma medications. OCT was done after that, but still, as you can see, the permanent synechia had been formed, and the pressure, it lowered to 32 mm Hg. After 1 month of giving steroid treatment when the eye was quiescent, we took the patient for phacotrabeculectomy with the mitomycin C. And since, as I told you, it's a very tricky surgery, we needed to use do the synechulisis and use the iris hooks, and a trabeculectomy was done. Post-op on day 1, the bleb was diffused and the chamber was formed, and the pressures was normal. And at 1 month post-surgery, the IOP was 10 mm Hg, the bleb was well formed, it was diffused as wanted. The vision improved to finger counting 1 meter. And then the fundus was examined and it was total glaucomatous optic atrophy. 3 months post-surgery, the patient had the IOP on the higher side, and we added glucomol 0.5%. So for this case, I would like to say that these patients, management for cataract and refractory glaucoma is very demanding, and there's a high risk of the failure of the filtering surgery as well because they have more inflammation. So in such patients where the IOP is not getting controlled, we need to do a combined surgery. Literature says that we can do a phacotrabeculectomy, but if possible, then we should do a cataract first, and then we should go for the trabeculectomy. So that can be given as a choice to the patient also if the IOP is under control. However, if there is, and as you see that in this case, the patient had a vision of PLPR, and we just did not know how much recovery will be there. But in such cases also, a treatment trial should be given because we could actually give some vision to the patient, and finger counting 1 meter is very useful to the patients as seen in our OPD. Thank you so much.
Okay, I have a question. When you took the patient for surgery, the intraocular pressure recorded was?
Ma'am, the pressures were high post-op after 1 month, but the eye was quiescent.
Pre-op, before surgery.
Yes, ma'am. It was around 25 mmHg, ma'am. And he was on Diamox, ma'am.
Okay, but then when you took the patient for surgery, the intraocular pressure recorded was 32 millimeter mercury?
No, ma'am. 32 millimeter was the pressure that we got when we did the ND-YAG laser for that membrane that we did, perforated the membrane. the chamber formed and the pressure lowered from 48 to 32. Not much, but it
and,
could be
and
an intermediate benefit.
pre-op surgery, the day of surgery, 1 day prior, how much was
Yes,
the
ma'am. The
intraocular
patient
pressure?
had a IOP of 25 mmHg
Okay.
before the surgery as well. After 1 month of waiting for the eye to be quiet,
That's
because
what I was
we
thinking.
cannot go for the
Okay.
surgery.
And pre-operatively, did you give any anti-glaucoma medication or IV mannitol or anything of that
Yes,
sort?
ma'am. We give a IV mannitol to the patient.
Did you? Was it mentioned here?
No,
I
ma'am,
think
it
I missed.
wasn't pre-op. It wasn't mentioned here. But whenever we take the patient for a phacotrabeculectomy or a trab, we give a IV mannitol to the patient.
And what kind of block did you use in such case?
We use a peribulbar block.
Okay, thank you.
Thank you, ma'am. Thank you, everyone.
Do you give, do you use MMC in these cases or?
Yes, sir. We use most of the. So we use MMC except in the high myope cases. We do not use the MMC.
Even in the first surgery you use MMC?
Yes, sir. We use MMC in the patient.
And do you do the trabeculectomy at the same site of the phaco incision or?
2 sides, sir.
Any particular reason for that?
So it has been quite successful, and in all our cases,
Nothing to do with uveitis.
so not particularly because of the uveitis, we do it 2-side surgery only because the results are good in our practice.
When you are giving a paper like this, you should quote your references. You have not provided your references here.
Yes, ma'am.
Number one. Number two, you said something that like cataract surgery should be done before the trabeculectomy. I think with something like that, you should have quotations, I mean, from noted authors before, because it is questionable.
Okay, ma'am.
Number three is that the preferred choice right now for uveitic glaucoma, because of the high failure rate, is of course
A valve?
is a valve.
Yes, ma'am.
So
But depends on the affordability also, ma'am, of the patient. For
I
in
do
our
understand it. I do understand that you did do that, but I think it would have been
Yeah,
wise to
definitely,
mention
ma'am.
it.
Definitely,
All
ma'am. Thank you for comments. Thank you, everyone.
Okay. Next, do we have Dr. Poonam Singh? Yes. Dr. Poonam Singh is going to talk about double trouble, ocular surface in eye with glaucoma on long-term topical anti-glaucoma therapy. Dr. Justin, please. Dr. Justin is going to present the spectral domain optical coherence tomography in the diagnosis of primary open angle glaucoma. Dr. Poonam, you can come up in the next one. Okay?
Good morning. I'm presenting my study on SDOCT in the diagnosis of primary open angle glaucoma. So in India, 11.2 million people have glaucoma, out of which 6.48 million people have POAG. Automated perimetry, also known as the HFA, was initially used to diagnose POAG. But this instrument had a problem with it. That is, it detected glaucoma only when 30% of the ganglion cells were already lost. So this is where SDOCT comes into its play in the field of glaucoma, especially with its parameters GCC and RNFL. But there are very few studies which were able to tell about the diagnostic capability of the GCC and the RNFL. It is for this reason that we have taken up this study. So my objectives were to determine the diagnostic capability of ganglion cell complex thickness and the RNFL using SDOCT in patients with POAG, and to determine the association of the structural and functional damage in POAG. Going on to the methodology, it's a cross-sectional study with a sample size of 90. Participants from the PIMS ophthalmology OPD were recruited after satisfying the inclusion and the exclusion criteria. They underwent a complete clinical examination, and then they were subjected to SDOCT and the HFA, and all the parameters were recorded. Going on to the salient results, out of the 90 participants, 43 were males, 47 were females. Age of presentation was between 42 to 85 years, with the average age being 55.63 plus or minus 12.5 years. So overview of the parameters, you can see that the average GCC thickness and the average RNFL thickness were quite similar. The AU-ROC curves were used to determine the sensitivity and the specificity of GCC as well as the RNFL thicknesses, which were 70.8% and 98.1% for GCC respectively, and for RNFL it was 82.7% and 91.7% respectively. one-way ANOVA test was used to find the association between the visual fields and the GCC and the RNFL thicknesses. For this purpose, our population, for the purpose of analysis, our population was divided into 3 groups based on the severity, as you can see over here. And you can see that all the values were statistically significant. And you can also note that the mean in the 3 groups between the average GCC and the average RNFL thicknesses were also very similar. To reaffirm the one-way ANOVA test, a post-hoc analysis was also done, where the difference in the thicknesses between one group and the other 2 groups were also compared for both GCC as well as the RNFL. And again, you can see that all the values were statistically significant, both for GCC as well as the RNFL thicknesses as given in these tables. Moving on to my discussion, the average GCC and RNFL thickness were around 79 microns, very similar. GCC thickness with RNFL also have an equivalent sensitivity and specificity, as I had mentioned in my AIOROC curves. Thereby, the difference in the diagnostic potency between the 2 parameters being statistically negligible. So, from this, my study corroborates the diagnostic ability of both these parameters equally. The means of the average GCC and RNFL thicknesses were very similar across all values of IOP, reinstating the equipotent diagnostic capability. The p-values obtained by the one-way ANOVA test proved to be significant, indicating that there is significant association or correlation between the GCC RNFL thicknesses and its respective visual field defects, which was again reinstated by the post-hoc analysis as well. So, but there was a limitation to my study, that is, we hadn't measured the central corneal thickness, which usually has a significant influence in diagnosing primary open angle glaucoma. So, to conclude, both average ganglion cell complex thickness and average retinal nerve fiber layer parameters have equal diagnostic capability in diagnosing POAG. Both average GCC thickness and RNFL thickness parameters have significant association too with the visual field changes in POAG. So, these are my references that I had mentioned here. Thank you.
Dr. Justin, just in a nutshell, can you please tell me what did you want to conclude in this study of yours? Like, what did you want to, what was the aim?
My objectives or my aims were to find out the diagnostic ability between GCC and RNFL and to see which was actually superior, ma'am. But my post-hoc analysis, ANOVA test as well as my AIOROC curves all corroborated to the conclusion that both were equally potent in diagnosing POAG. Nothing was superior over the other.
Were these cases already diagnosed cases of POAG?
Yes, ma'am. We diagnosed it with the help of the HFA and then they were subjected to the
so when the case is a diagnosed case of primary open angle glaucoma, so what was the need of doing the GSSC and the RNFL thing?
Just to find out the superiority, ma'am. Actually, when my study started, we actually had 3 groups, the normal ocular hypertension groups as well as the POAG groups, among which we wanted to do the elaborate comparison. But my institutional scientific committee did not approve of that, because they wanted to keep it simple, so I had to stick myself to do these the only group in which I used. That's why I had used a post-hoc analysis to convey my one-way analysis.
So primarily, this study was just for an education or academic sort of thing.
Yes,
not for any diagnostic purpose, because
yes,
all these cases were primary open angle.
And this was across all the IOPs as well, because we know that SDOCT mainly plays a role in the pre-perimetric glaucoma.
Yeah, that's
Otherwise,
what
it's taken over by the HFA.
I wanted to come to that actually, but in these cases, they all were diagnosed cases of primary open angle glaucoma.
Yes, ma'am.
Okay, it was just a research work that you
just
actually
a research work to
right.
find GCC
Thank
and
you.
RNFL.
Thank you.
Thank you, judges.
Dr. Poonam, are you ready?
Good afternoon, everybody. Ocular surface evaluation in eyes with chronic glaucoma on long-term topical anti-glaucoma drop. We all know that as the age advances, most of the patients suffer with dry eye. So dry eye in chronic stage is related to ocular surface disorder. Also, glaucoma is a disease which, as we all know, causes increased IOP, visual field defect, optic nerve defect, and it is a lifelong disease which requires treatment throughout the life. Both these diseases are prevalent in elderly patients. There are n number of factors which can cause dry eye, and taking glaucoma medication for long term is also one of the factors for ocular surface disorder. So, if a patient with age having glaucoma and also having dry eye individually has a problem, but together it causes a double trouble. So, the aim of this study was to establish the prevalence of ocular surface disease in patients who are using anti-glaucoma medications, and also to compare the frequency and severity of their symptoms with the control group or of normal subjects which are age matched. So, the patients, the study and control group had 103 patients in each group. The ocular surface disease index questionnaire was given to all the patients. Tear breakup time was recorded, Lissaman green staining was done, and a Schirmer test was done. All the patients who had previous any corneal or conjunctival disease and who were on topical steroids or contact lens wear were excluded from this study. This is the questionnaire which was given to the patient, which has some questions, and the scoring is done, and the ocular surface index is calculated by doing a OSDI, where the sum of the scores multiplied into 25 and divided by the total number of questions which the patient answers. This is too simple for here, that tear breakup time is from the last blink to when we see the first appearance of the first dry spot, and it tests the stability of the tear. Lissaman green staining was done, and it was calculated on the basis, graded on the basis of the score where there were how many spots were present in which area. And a Schirmer test was done, and it was graded on the basis of mild, moderate and severe depending upon how many millimeter of wetting was there. When we see the results, both the groups, whether it was control or the study group, they were comparable as compared to the age and sex matched. The ocular surface disease, whether in all the three tests which we did, whether it was a tear breakup time or Schirmer test or a Lissaman green staining, we can see that the patients who had glaucoma had more dry eye as compared to the normal patients. When we see the tear breakup time, fluorescence staining tear breakup time, we see that the prevalence was more in cases of glaucoma patient, which was 83.5% as compared to the normal group, which was 57.3%, and the p-value was significant to the value of 0.001%. When we compare the Schirmer group in two groups, we see the prevalence is 30.1 as compared to 17.5. It is not highly significant when we do the p-value, but still there is a difference present there. Ocular surface staining also showed that the prevalence was high in glaucoma patients, 62.1% as compared to 31.1% in normal patients, with the p-value which was highly significant. When we compared the patients who were having different amount of medication, whether one medication, two medication or three medications, we did not find any significant p-value changes. However, there are many studies which show that there are certain changes which are available, but in our study we did not find any changes. When we compared the quality of life in these patients, we found that as the disease, as you can see, that as the patient has mild to moderate to severe disease, the quality of life in glaucoma patients is affected as compared to the patients who are normal initially. So, these are my references, that prevalence of ocular surface disease is present in glaucoma patients, and dry eye does affect the specific quality of life in patients who are using glaucoma medications for a long time, and ocular surface disease impacts the patients who are having glaucoma. So, to conclude, ocular surface disease is more prevalent and worse in long-term glaucoma treated patients than their age and sex matched counterparts. Severity of ocular surface disease is more in patients who are taking multiple drug regimes. However, it was not seen in our study, and the quality of life in glaucoma patients is affected due to ocular surface disease. Thank you.
So, I have a question.
Yes.
Thank you for your presentation. You have not given a time range, have you, in this, because you have spoken about time in the conclusions, but over what time, that is one question, and these patients have been followed. And the second thing that is not mentioned of, which is whether the presence of dry eye is there previous to starting the medication or not.
Yeah, ma'am. All these patients know, you are absolutely right. I did not mention the duration of time. Actually, we have these patients, we have, where we have a follow-up this patient. It's a corporate hospital where I'm working, and they come up to us for almost 20 years also together. We have been seeing these patients. So we had kept a criteria to first time visit. The evaluation was done. However, it has not been shown in this study, ma'am. That was a part key first time, and then how much duration. Here we have randomly taken the patients who are already on medications, maybe 3 years or beyond, and the patients who are normal, age matched. But
One more marker for dry eye in anti-glaucoma medication could be to study the globulate cell morphology of the conjunctiva.
Yeah, ma'am, we do need a cellular matrix and all the pathology department to help. We have kept it in mind, ma'am.
Yes,
Yeah.
probably
Yes,
that could be one of the
Yes.
good things.
Yes.
Okay, apart from any, what is the alternative for such patients?
That's what I missed that slide where, ma'am, these are the patients because we can, these days, 3 things are there which we can do. One is that lubricating drops can be given on a regular basis. And the other thing is now we have much better medications which are available, because mostly the medications they themselves have some preservatives which will be affecting the causing the dry eye or irritation. So rather than giving 4 drugs, if we are possibly giving a combination of drug and reduce it to 2, maybe we will reduce some amount of discomfort to these patients.
Absolutely. Thank you.
Thank you, ma'am.
Excuse me. Sorry. Did any of your patients have pseudopemphigus, or did you see for that? Because that can affect the dry eye parameters to a great extent, actually.
None of them, sir.
It was not actually
Yes.
mentioned there, so I was wondering. Yeah, thank you.
Is Dr. Shantanu here? Dr. Shantanu? Dr. Shantanu Gulati is going to present the blood flow assessment of optic nerve and glaucoma.
Good afternoon, everyone. I'm Dr. Shantanu Gulati, and I'll be presenting blood flow assessment of ONH in glaucoma. So the principal mechanical theory of glaucoma does not actually explain the observations that we see, such as NTG, where the IOP does not typically cross 21 mmHg. And also a proportion of treatment groups in a lot of eminent trials have shown that there has been glaucomatous progression despite achieving the targeted IOP for the set of patients. So currently lowering IOP is the only treatment that we have for glaucoma. So the aim of this study was to uncover evidence that supports association between ocular blood flow and glaucoma. We had a cross-sectional design and 88 eyes from 44 patients. We included patients who had open-angle glaucoma, normotensive or ocular hypertension along with age-matched controls, and we excluded any patients who had altered hemodynamics such as CVA or anemia, or those who underwent cataract surgery, and also the non-consenting ones. So the open-angle glaucoma was 26 eyes. 20 of these were both eyes of the same patient and 6 were unilateral eyes. The controls had 34 eyes, so 28 were the bilateral and 6 were the unilateral eyes from the OAG group. Ocular hypertension was 12 eyes and normotensive glaucoma group had 16 eyes. So we performed an ocular color Doppler imaging with the radiology department on the ophthalmic artery, the central retinal artery, the lateral posterior ciliary and the medial posterior ciliary arteries along with the carotid Doppler, and we measured the peak systolic and diastolic velocities and the resistivity index. So coming to the results, for the resistivity index, we found that in cases of in ophthalmic artery, the resistivity index was more than the cutoff value as seen in NTG and OAG with statistical significance. In LPCA artery, it was seen to be more than the cutoff in NTG and POAG again. And in MPCA group, it was more than the cutoff in NTG, POAG and ocular hypertension, of course with statistical significance. In the case of central retinal artery, it was within normal limits for all the patients, and the resistivity index of internal carotid artery was also within normal limits. Coming to the next parameter, the end diastolic velocity, we found that in ophthalmic artery, it was less than the cutoff in controls for normotensive glaucoma group. For the central retinal artery, it was again lesser only in the normotensive glaucoma group. For LPCA, it was lesser in NTG and OAG groups, and in MPCA, it was lesser in NTG, OAG and ocular hypertension. So basically in normotensive glaucoma, the mean EDV was reduced in all 4 vessels, in open angle glaucoma in both the posterior ciliary arteries, and in ocular hypertension in only the MPCA artery. The mean PSV of retrovalvular vessels yielded no statistically significant differences between the controls and study groups, and the carotid Doppler study was also normal. So this basically points to the vulnerability of optic nerve head in normotensive and open angle glaucoma, more so in normotensive as seen in our study, implicating a predominant vascular component. And there are various other studies that also corroborate to the same, such as a study by Galassi et al., who showed the same findings as ours. And also in their study, they correlated it with visual field deterioration and found that patients with a higher resistivity index were more likely to have visual field deterioration. So I conclude that the vascular indices as measured by OCDI in decreasing order of importance are resistivity index more than end diastolic velocity and more than peak systolic velocity. And among the vessels, the involvement of ophthalmic artery and posterior ciliary arteries was found to be most important. So we recommend that a detailed history regarding the cardiovascular and systemic medication can be obtained, and color Doppler imaging can become a part of a routine part of glaucoma workup.
Chair, moderate, time is over.
Okay. Any questions from anybody?
Did you check the lipid profile of these patients?
Yes, sir.
So was there any correlation, or it was just...
So they were excluded. The patients who had an altered lipid profile were excluded from the study.
And how do you manage such patients if you have a vascular component in the glaucoma?
So there have been studies that have given medications like calcium channel blockers, but apart from that, you can give neuroprotective agents.
Like
Bitoxolol, brimonidine.
Okay. And any relation with intracranial hypertension?
So we didn't see for that in our study.
That part you don't know. Okay. All right. Thank you.
Okay. Next is Dr. Athilji. Is she here? Athili. Is Dr. Athili here? No? Okay. Dr. Shovik Barua, are you here? Dr. Priyanka? Dr. Priyanka Mandhara is going to present on identifying when it's not glaucoma, a dilemma.
Very good afternoon to everyone. My topic of presentation is identifying when it's not a glaucoma, a dilemma. An optic neuropathy can be discussed under topic optic disc changes, visual field effects, and RNFL changes. Current definition of the glaucoma preclude IOP for diagnosis. Optic disc changes are central to making diagnosis, but cupping is not synonym with glaucoma. Misdiagnosis lead to the serious consequences, visual loss, health, and well-being. Non-glaucomatous optic disc cupping, physiological, compressive, ischemic, congenital, hereditary, traumatic, toxic, inflammatory, and degenerative. Physiological cupping can be differentiated on the basis of uniform neuroretinal rim and absence of RNFL defect. Compressive optic neuropathy can be differentiated on the basis of disc pallar in excess of cupping, particularly of temporal rim, a vertical step in the visual field suggestive of compressive optic neuropathy. Ischemic optic neuropathy have the features of sudden, painless, unilateral loss of vision and attitudinal field defects. Some of the other congenital and hereditary optic neuropathies can be differentiated on the basis of variable, non-progressive visual field defects and early age of presentation with long-standing nature. In Leber's hereditary optic neuropathy, there should be a careful history, duration, and progression are helpful cue. In traumatic optic neuropathy, disc pallar is more than excavation and history of trauma should be present. In methanol poisoning, there should be a history of alcohol intake. Consider all the clinical information in making diagnosis, distinguishing glaucoma from non-glaucomatous optic neuropathy. Avoid misdiagnosis. A detailed history leaves the clue in many alignments that mimics the glaucomatous optic neuropathy. A positive family history present in glaucomatous optic neuropathy, while there is a presenting history of sudden, rapid, painless loss of vision. Keep in high level of suspicion, do a careful examination with an open mind with visual acuity, pupillary reaction, color, vision, neuroretinal rim, and visual field. Central visual acuity should be preserved until advanced stages in glaucoma while reduced in early stages in non-glaucomatous patients. Ipsilateral RAPD with the reduced visual acuity present in non-glaucomatous optic neuropathy while RAPD present with the good visual acuity in asymmetrical glaucoma. In glaucomatous optic neuropathy, there is color vision deficit with preserved central visual acuity, while in non-glaucomatous optic neuropathy, there is color vision deficit with reduced visual acuity. In non-glaucomatous optic neuropathy, visual acuity is poor in comparison to cupping, while in glaucomatous patient, there is a central visual acuity much better than cupping. All the primary glaucoma are bilateral and usually symmetrical, but in non-glaucomatous optic neuropathy, there is unilateral and asymmetrical glaucoma. Rim pallor is more than cupping in non-glaucomatous optic neuropathy, while localized rim loss in glaucomatous patients. Central, secocentral, attitudinal, hemianopic field loss are present in non-glaucomatous optic neuropathy, while paracentral, arcuate, and nasal steps present in. My take-home message from this presentation is age less than 50 years, suggestive of non-glaucomatous optic neuropathy. Visual field is poor compared to amount of cupping in non-glaucomatous optic neuropathy. Preserved neuroretinal rim is pale and think neurological. Visual field defect that respect vertical meridia should never be accepted in glaucoma. Rapid progression of vision loss, field loss, asymmetrical neuropathy points towards neurological. Thank you.
Very nice and important presentation.
Thank you.
It would have been beneficial for your presentation if you would have given some references. But it was good.
Thank you, ma'am. Thank you, sir.
Any more questions from the Okay. Thank you. Next is Dr. Amrita Verma. Are you here? Dr. Amrita is going to talk about idiopathic intracranial hypertension, a diagnostic dilemma, down an unfortunate road.
Good afternoon, respected judges and my dear colleagues. So I'll be talking about idiopathic intracranial hypertension, a diagnostic dilemma down an unfortunate road. As we know, IIH is a syndrome characterized by raised intracranial pressure of unknown or idiopathic origin associated with various non-localizing ocular findings. It was initially thought that it is restricted to young overweight females. The notion is wrong, definitely, because it can develop in both males and females of all ages and body types.
One moment.
The incidence is around 1 per 1 lakh, and most common finding is papilledema. Other presenting symptoms can be headaches, tinnitus, temporary blindness, double vision, blind spots, neck and shoulder pain, and peripheral vision loss. So we diagnosed our patients based on the modified Dandy criteria. Coming to the materials and methods, it was a retrospective observational study where 10 consecutive patients with symptoms and signs of IIH confirmed with MRI and CSF tab fulfilling that criteria were taken. We evaluated the BCVA, anterior and posterior segments, visual fields, OCT RNFL, the MRI and MR venography, and CSF pressure reading, usually greater than 250 millimeters of water was taken as diagnostic. Visual field grading was done by Wall and George grading, and Moorfield Fresson scale was used for papilledema grading. So coming to the results, there were 80% of them were females and 20% were male, with age representation from 18 to 56 years, but maximum patients were above 40 years of age. Obesity was seen only in 40% of the cases, with headache being the symptom at presentation in maximum number of patients. Previous episodes of transient visual loss was seen in among 50% of the cases. The visual acuity ranged from 20/20 in almost 8 patients to PL positive and PR accurate in 1 patient. RAPD grade 1 was seen in maximum patients. Papilledema of grade 1 was seen in 7 patients and grade 5 only in 1 patient. Coming to the visual field analysis, it was non-recordable in 1 patient, normal in 6 and abnormal in 3 patients. And the opening pressures, they varied from 320 to 250 millimeters of water. Coming to the OCT RNFL, only 1 patient showed an abnormal OCT RNFL. The MRI findings, it was seen that enlarged pituitary with tortuous bilateral optic nerve was seen in 1 patient. Perioptic nerve sheath distension was seen in 4 patients, empty saline 2 patients, and 2 patients had normal findings. So gender is an obvious risk factor from here also, because over 90% of the patients affected are women. This suggests that hormones are playing a role in pathophysiology of the disease. However, studies of hormonal differences have been inconclusive till now. Diminution of vision at presentation was deemed as a poor predictor of the visual outcome. The visual outcome showed a significant association with CSF opening pressure in univariate analysis, and papilledema is routinely used along with visual fields to monitor the treatment. Patients with high-grade papilledema with diminished visual acuity at presentation are more likely to experience treatment failure. However, fundus grading definitely can be dubious because of the inter-rater variability which is there. It should not be confused with optic neuritis, which is common at this age, and in our study neither the grade of papilledema nor the type of visual defect correlated with worse visual outcomes. In view of these difficulties, we tried to determine the role of monitoring RNFL thickness in IIS for monitoring the clinical response, but we could not establish any significant correlation between the thickness and the visual outcome too. Though high CSF opening pressure, worsening vision, papilledema, and greater RNFL thickness may be some of the alarming signs for IIH, but they cannot be considered independent. And visual loss at presentation is probably the most important predictor of the final vision in these patients. So early diagnosis and prompt multidisciplinary management is the need. Concluding, the axonal loss occurs in patients despite apparent treatment sometimes, and multidisciplinary approach in is promptly required. We could not do a VEP or contrast sensitivity in the patients, that is the limitation, and BMI was not calculated because it is a retrospective, so we did not actually do it. And these are my references. Thank you.
What are you trying to prove through this study? I mean, these things already documented. And
yes, sir. Actually, the thing is, 1 or 2 of the patients in this study, especially the one with PLPR vision, she had been treated twice as retrobulbar neuritis, and the patient kept worsening, and when she came to us now, she was at the stage of VP shunt. So that is what I want to tell, that even when you see the MRI, you should always consult a neurologist, because sometimes you cannot make out if it is an optic neuritis or an IIH, which has a very bad prognosis. So that is why we...
I mean, that was a diagnostic problem with the person who diagnosed it.
Yes,
Actually.
but I have seen that in multiple cases, you know, I mean...
How do you manage these cases?
So, sir, as said, we always go
surgical,
with the...
Any surgical
VP shunt was done in one of the patients, but from the ocular side, no surgery. We go in with the neurophysician, which is there with us, and mannitol is used, Diamox is used, topiramate is given for a longer time, and if required, if it is still not responding, VP shunts are put for such patients.
We have a series of 91 cases managed with optic nerve fenestration, transconjunctival. So
in IIH
yes,
cases.
with very good results.
Okay, okay.
And, okay, fine. And have you ruled out venous thrombosis in such cases?
Yes, MRI and MRV both were done, because so nowadays we are, since the last 3 months, we also get a DSA done for such patients.
What visual field changes you
DSA,
see?
sorry?
Visual field changes?
Sir, only in 1 patient we could, in 3 patients we had a central scotoma, we had very partial loss.
Okay, thank you.
Thank you.
Okay. So do we have Dr. Uma Shroff here with us? Dr. Uma is going to present a case of homonymous hemianopia post-COVID infection.
Good afternoon, everyone. I would like to present a case report of left homonymous hemianopia following COVID-19 infection. As we all know, COVID-19 is caused by SARS-CoV-2 virus, and it led to a worldwide pandemic. We all have faced the consequences of the COVID-19 infection. The manifestations of the disease are greatly variable, from mild flu to life-threatening condition, and ophthalmological manifestations are reported in approximately 2 to 32% cases, whereas CNS involvement is reported up to 0.1 to 25%. That is the wide percentage is reported in various papers. The symptoms would include most commonly of anosmia, ageusia and headache, and less commonly stroke, impaired consciousness, seizures, encephalopathy, venous sinus thrombosis, etc. Result of the viral neuroinvasion can occur from transsynaptic route, vascular endothelium, or leukocyte migration. Moving forward to the history, a 57-year-old female patient presented to our OPD with chief complaint of left-sided defective vision since 6 months, and she had a past history of COVID-19 infection, which was 6.5 months back, and she developed a left-sided stroke 6 months back. That is after 15 days from contracting the COVID-19 infection. One episode of seizures was following COVID-19 infection 5 months afterwards. On examination, the patient was general examination was all normal, except the patient has left-sided hemiparesis. And visual acuity, to our surprise, as patient complained of left-sided DOV, but on examination, the visual acuity was better in left eye and worse in right eye. Anterior segment examination was normal, except pupil had RAPD in left eye, and ocular movements were slightly restricted, abduction in both eyes. Visual field charting was done on Humphrey Visual Field Analyzer using 30-2 program. Here is the Humphrey report of the patient showing left-sided homonymous hemianopia and severely depressed visual fields in the right eye. So the MRI scan, the patient already had this MRI scan with her, as she also developed a stroke. So the MRI had this large subacute to chronic infarct involving right frontoparietotemporal occipital lobes, including basal ganglia with cortical laminar necrosis, and there was no flow related enhancement noted on the right middle cerebral artery on angiography. These are the blood reports, which are essentially normal in the patient. The management was symptomatic from our side, so we prescribed 30 PD base out prism for Fresnel prisms for symptomatic improvement, and patient received the anti-hyperlipidemic plus anticoagulant, antihypertensives, and diuretics from the neurophysician. So, okay, we can skip this.
Conclude.
So, thank you.
Conclusion, you can conclude.
You can conclude.
You can tell
slide.
us.
Yeah.
Yes, ma'am. So all the reviewed studies demonstrate that neurological manifestations are broad and heterogeneous, suggesting different underlying pathological processes and pathways. Even though neurological manifestations represent a very small portion of COVID-19 manifestations, these can be life-threatening and sight-threatening, leaving the individual with lifetime of serious impairment. Identification of such manifestations is crucial in early treatment and recovery. So, thank you.
Okay, thank you. What was the relation of COVID with your paper?
Ma'am, this patient had COVID-19. She contracted this in the first wave in March 2020, and in April itself she developed this stroke and left-sided defective vision. But the patient did not present to us at the same time because she was admitted elsewhere for the stroke and all. And after recovering, actually she was recovering from the stroke when she presented to us. Even she was able to walk also. She came in walking, not on wheelchair. She came in walking to us, but
so you want to say that the COVID caused the stroke?
Yes, ma'am. Yes.
Okay.
There have been vascular episodes post-vaccination also. So,
Yeah, I was about
have
to
you did you find out whether the patient was vaccinated or?
Sir, the patient was not vaccinated. It was very early in the first wave itself.
And coagulation profile of the patient, the parameters that we usually see, did not mention?
Like any other systemic illness the patient had?
No, ma'am. The patient did not have any other systemic illnesses also. And sir, lipid profile was normal that I have mentioned in the
D-dimer.
no, the D-dimer
Those are
and
the
all was
important
not
tests you look at when you want to talk
And
about.
literature, what does the literature say? Any other story? This is anecdotal. I mean, yours is the first case, or is there anything else has been reported?
I have found one more case of the similar homonymous hemianopia in the
Did
literature.
you mention that in your paper?
Sorry?
If you had mentioned that in your paper, we would have corroborated your findings rather than it being an anecdotal association kind of thing. There is no causative, what we are trying to say is there's no causative thing between COVID and the homonymous anomia. You have not shown that.
Yes, that's the drawback of my case.
Okay. Thank you. Is Dr. Gitanjali Sood here? Dr. Gitanjali is going to present us with vitreopapillary traction, a missed or underdiagnosed entity.
Good afternoon, everyone. I'll be discussing about two cases of vitreopapillary traction, which is an often missed or underdiagnosed entity. So the first case is a 50-year-old female who came for second opinion regarding her optic disc edema. She had already undergone MRI, visual field and neurological examination before coming to us, which were all normal. She did not have any history of headache. Her best corrected visual acuity was 6/6. Other anterior segment examination was normal. So coming to the fundus photograph, what we see is a bilateral blurring of the disc margins. But the other entity is we can see a epipapillary membrane that is present over the disc in the right eye and a faint membrane in the left eye also. So we did a OCT scan, and the raster scan revealed the presence of bilateral hyperreflective membrane as shown by this white arrow, which is present over the disc and causing traction in both the eyes. Why it is not true disc edema? Because there is absence of clear space underneath the nerve fiber layer, and there is no bowing of the RP as we can see here. So in the absence of any underlying organic pathology, a diagnosis of vitreopapillary traction was made, and patient was followed up over 1 year with stable vision and no progression of traction and edema of the optic disc, and no visual field defect was developed. The second case is a 60-year-old female who developed diminution of vision in right eye for past 3 months. She came with the best corrected visual acuity of 6/12 and left 6/6. Anterior segment evaluation was, there was bilateral nuclear sclerosis, right more than left. Other things were all normal, color vision, visual fields. So dilated fundus examination before surgery, we noted bilateral blurring of the disc margin in the left eye. There was sparing of the temporal disc margin, but the surrounding vessel architecture is all normal and there are no macular changes. So we did an OCT scan. So what we see here is an posterior vitreous detachment that is still attached at the disc and more so at the nasal margin, causing traction of the nasal margins in both the eyes. In this, the PVD has been induced temporally, but here the vitreous is adherent, but only on the disc it is causing traction. So a diagnosis of vitreopapillary traction syndrome was made in this patient also, and she underwent cataract surgery, and on follow-up she recovered good vision. So what is vitreopapillary traction? It is a syndrome used to describe the traction caused by abnormal vitreous condensation at the optic nerve head during the evolution of the posterior vitreous detachment, and the similar condition can also arise due to presence of abnormal glial tissue at the optic disc. So the etiology is idiopathic due to PVD, or secondary due to proliferative diabetic retinopathy, or vascular occlusions, or epiretinal membrane, or AION. The histopathology reveals vitreous fibrils meshed with glial cells, fibrocytes, astrocytes, RP cells, and myofibroblasts. The clinical features can be either peripapillary or disc hemorrhage, subretinal hemorrhage, blurring of the disc margins. Mostly it is a unilateral entity, really it can be bilateral. The symptomatology ranges from asymptomatic cases on long-term follow-up to diminution of vision and field loss, mostly noted in cases of secondary VPT, that is due to exoplasmic stasis. The field loss in VPT and vision loss were documented to be reversible after surgery. So the management in asymptomatic cases is a follow-up of these patients with OCT and vision and visual field evaluation, and symptomatic cases need surgical management with pars plana vitrectomy, PVD induction and peeling of the residual membranes. So to conclude, a relatively uncommon entity with benign nature should always be kept in mind by ophthalmologists when we are dealing with the patients of unilateral or bilateral disc edema, as ruling out by simple OCT scan can prevent us subjecting the patient to unnecessarily investigations. Thank you.
What is the mechanism of vision defect in this condition?
So it has been noted due to because the membrane is pulling off at the nerve fiber layer, so it leads to exoplasmic stasis. So that is causing that.
So what kind of visual defect you see?
Yes, sir?
What kind of visual defect?
It is like central scotomas or the enlargement of the blind spot.
The patient is symptomatic with a
In our patients were asymptomatic. I read the literature, but there were fairly central.
So it's an incidental finding basically.
Yeah. So
it's a known entity.
it is a known entity like vitromacular traction. It is less frequently known and diagnosed, but it is a known
So you
entity.
wanted to just highlight that.
Yes.
Okay, thank you. Next is Dr. Rachna Mandli. Are you here? Next is Dr. Sonali V. Kumar.
Very good afternoon to all of you. The paper which I am going to discuss today is clinico-pathological profile, management and outcomes in recurrent cases of ocular surface squamous neoplasia at a tertiary care center. So OSSN is a common neoplasm of ocular surface with significant morbidity. Recurrence is a problem, whatever is the treatment modality. And the treatment in this case is difficult, and the challenges posed by these lesions need to be unraveled. However, there are very few studies which have analyzed the outcomes in these cases. And this study was conducted to assess the clinico-pathological profile and outcomes in recurrent cases of OSSN. It was done at Army Hospital Research and Referral. It was a prospective cohort study done for 18 months. Recurrent cases of OSSN were included in the study group, and recently diagnosed cases of OSSN were excluded. 18 patients were recruited, and detailed history was taken and comprehensive eye evaluation was done. Histopathological examination was done where the biopsy was performed, and systemic evaluation was done which included the examination of lymph nodes. In our center, we formulated our treatment protocol depending upon the extent of the lesion and based on results of already published studies. Like in small lesion, we performed wide excision with cryotherapy. In medium lesion, we started interferon, and in patient with the orbital spread, we performed exentration. The primary outcome measure was complete response to the treatment with no evidence of recurrence after 12 months, and secondary outcome measure was complication associated with each treatment modality. The mean age of the study population was 64 years. There were 15 male and 3 female patients. Most of the patient had unilateral presentation. The right eye was involved in 14 patients and left eye in 4. The common site which was found involved was nasal quadrant, and the common size of the tumor was less than 5 mm. Common tissue which were found involved were limbus and conjunctiva. The common clinical presentation was papuliform mass, and most of the patient had vision from 6/6 to 6/12. Common associations which were noticed were smoking, HIV, HBsAg, and xeroderma pigmentosa. As per AJCC classification, 11 patients had T1 grade, 6 patients had T2, and 1 patient had T4 grade. Squamous cell carcinoma in situ was found in 3 patients and invasive type in 11 patients. In 2 patients, positive margin was found. For that, adjuvant chemotherapy was started. We performed biopsy in 11 patients, and in 6 patients we started interferon, and in 1 patient the exentration was done. So in patient where biopsy was performed, complete response was seen, whereas in cases where we started interferon, response was noticed in 4 patients, and incomplete means the tumor size got reduced but it didn't disappear completely. So this is a clinical photograph of a patient who has undergone excision with a complete recovery. This is a photograph of a patient in which we started interferon and shown complete regression of the tumor. This is a case which had an orbital spread at the time of presentation, and exentration was performed. So the current study demonstrated that the mean interval between the initial intervention and the tumor recurrence was 7 months. This is in conformity with Kaire et al., which also confirmed the similar finding. The main cause of recurrence in the current study was in the incorrect diagnosis, and the patients were not followed up at the initial center. Common pathological grade which was found in the study group was invasive type, which was in concordance with Mirza et al., which also reported invasive type, and whereas Lee and Lau et al. Reported SCC type of carcinoma in the study population. The treatment with different modalities achieved a good outcome in all cases with no sign of recurrence over a period of 12 months. Sturge and Palmer et al. Also reported a nil recurrence in the study group. So this is the first study which has analyzed the outcome in recurrent cases of OSSN. We did not find any sign of recurrence after 12 months of follow-up, and the common cause of recurrence was found to be the misdiagnosis of the lesion. So the study has laid down certain guidelines for carrying out the research on a recurrent cases in a larger population. The limitation was a small sample size and short follow-up. So recurrent is a frequent challenge in the management of OSSN. Even in recurrent OSSN, if the various factors are not taken care of, risk is very high. Timely diagnosis and adopting appropriate treatment strategy is of paramount importance to alleviate the recurrence rate in this disease entity. Thank you.
How common do you see these cases?
Ma'am, our is a tertiary care referral center, so we do get lot of cases, like from the northern and the western part of the India.
Okay, okay. Any questions from the panel?
How do you diagnose recurrence in such cases where the treatment is incomplete or wrongly diagnosed? It could be, it may not be recurrence, it may be the primary tumor which has not been treated.
Like in our setup, like I have told you, all were the referral patients. So they came with the proper notes. It was done, some intervention was done somewhere else. And then they didn't go to that previous center where it was treated. And then
you said it was misdiagnosis, isn't it?
Yeah, because they performed like all the like plain simple biopsy was done, means excision was performed in all the cases.
So that's not recurrence, that's like incomplete treatment.
Yeah, means you can say like it was not like normally in case of OSSN we take 4 mm of conjunctiva and then we excise it. So that was not done.
Okay.
Thinking that it's pterygium or actinic keratosis.
Okay. Yeah.
Thank you.
Good. Okay. Next, do we have Dr. Athira? Yeah. Dr. Athira is going to present to us retinoblastoma or orbital cellulitis, a diagnostic dilemma.
Good afternoon, everyone. I'll be presenting on retinoblastoma or orbital cellulitis, a diagnostic dilemma, a case report. I have no financial disclosures or conflict of interest with this material of presentation. Coming to introduction, retinoblastoma is the most common ocular malignancy in childhood, which is lethal and if left untreated. Different modes of retinoblastoma presentation comprise proptosis, anterior chamber inflammatory signs, spontaneous hyphema, secondary glaucoma, and strabismus. My case report, a 3-year-old boy presented with recent onset of orbital swelling, pain, redness, and discharge from left eye. He received initial treatment for this from nearby civil hospital, but he did not improve. So he presented to us with orbital swelling, pain, and redness. And there was no history of any other systemic illness or any ocular illness in the past, according to the parent. And there was no similar history in the family. Materials and method. On examination, lids and periorbital tissue was swollen, and rustitis couldn't be examined due to lid swelling. And treatment has started for orbital cellulitis, and symptoms were subsided, but vision was not improved. It was still PL doubtful. We couldn't examine the posterior segment. It could not be visualized. And with many investigations, like CT, it showed non-specific intraocular tumor, but MRI suggested endophthalmitis. Ultrasound also we had done, which showed minimal enhanced lesion. All routine investigations and metastasis workup have done, but we didn't get any positive findings. After discussing with pediatric oncology department, enucleation of left eye was done under general anesthesia. This is a picture of my patient, which post-operatively, patient was given topical antibiotics and systemic antibiotics. And we have sent the specimen for histopathology, which showed homerite rosettes, small round cells, pseudo-rosettes, which is suggestive of retinoblastoma, but with no extraocular extension. And patient is currently under follow-up. Coming to discussion, there have been many studies have conducted on atypical presentation of retinoblastoma. Some studies reported they presented as floaters or endophthalmitis, and some people presented as total hyphema. In conclusion, atypical cases of retinoblastoma may lead to diagnostic dilemmas. Retinoblastoma can mimic any orbital or ocular pathology, which is that possibility of ocular tumor should be kept in mind when we treat these kind of diseases, these kind of symptoms. It can prevent the progression of the disease to advanced stages and decrease morbidity and mortality. These are my references. Thank you.
Just one question.
Yes.
You showed the photograph of the patient.
Yes.
Was a proper consent taken?
Yes.
Any comments from anybody? Okay, thank you.
Thank you.
Next is Dr. Shraddha Savani. Dr. Shraddha is going to present to us the conjunctival hyperpigmented lesion.
Good afternoon, everyone. I am Dr. Shraddha Savani, going to present a surgical management of conjunctival hyperpigmented lesion with amniotic membrane transplantation. Introduction. Pigmented conjunctival lesion exhibit a wide variety of appearance, and the differential diagnosis of this include the nevi, melanosis, and malignant melanomas. The amniotic membrane transplantation can be used to reconstruct the conjunctival defects created by the surgical removal of such pigmented tumors. A case report. A 5-year-old male child brought to our hospital with a blackish discoloration of right eye since birth, which was painless, gradually increases in size with age. On detailed examination, the large pigmented lesion of 5 × 9 × 1 mm over the bulbar conjunctiva, temporally with the raised anterior segment, ocular position, movement, and the posterior segment is normal. This is the pre-op photograph of the patient. We can show the temporary there is a hyperpigmented lesion. A written and the informed consent was obtained from the parents prior to surgery, also for the use of the amniotic membrane. The excision of the lesion and the amniotic membrane graft was used for the reconstruction of such ocular surface under the general anesthesia. The resected tissue was sent for histopathological examination, which revealed the small nest and the clusters of the benign melanocytic cells containing extensive melanin. There is no evidence of malignancy is noted, and which is diagnosis conjunctival nevus. This is an intraoperative photo. The first photo will show that there is we resect the lesion, and the second photo is for amniotic membrane transplantation. And this is the post-op 6-month photograph. This shows the healing of patient. Discussion. Regular self-examination in which a patient recognizes suspected lesion have been shown to be important for the prevention of and early detection of melanomas. To help the patient identify the suspected lesion, ABCDE rule often recommended, which include the several clinical melanoma features. In our case, the large bulbar conjunctival pigmented lesion with color variation in size progression was known. Removal of such a lesion can be therapeutic challenge. The effectiveness of the transplantation sufficiently indicated as a supplements of collagen layer and basement membrane. The MT have been found to be a good choice for the reconstruction and the restoration of the persistent epithelial defect of the cornea as well as conjunctival defects. In our case, we decided to reconstruct the vast conjunctival defect using the amniotic membrane, and this eye's course of healing was quick without scarring and complication. The conclusion is a surgical excision combined with amniotic membrane transplantation reconstruction is effective and economical for the treatment of large conjunctival lesions. AMT should be considered as a secure and easy option in the reconstructive ophthalmology.
Very good, actually. Very good. Any questions from anybody?
So the amniotic membrane is placed even before histopathological diagnosis, or
no, sir. It is in the one time we do procedure, surgical excision with amniotic membrane transplant. This is a big lesion, so we decided to transplant the amniotic membrane. Thank you.
So with this, we conclude the free paper session. Thank you to all presenters. Thank you our chairperson, co-chairperson, convener. Thank you everybody for your patient hearing.
Thank you. You must take a photo. एक साथ वो ले
so much, everybody. Thank you. Well done.